everybody. Recording live from somewhere. This is Zach Couples with episode number 127 of the Movement Debrief. And today, folks, grab your pumpkin spice lattes because we about to go basic. Because we're going to talk about infrasternal angle treatments 101. You got an infrasternal angle, you measured it, you're all excited, and then you're like, what do I do about it? That's what's going to be answered today because your boy, Big Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Tyler. Here's what Tyler asks. Hi, Zach. I hope you're doing well during these times. Thanks again for all the content. I have a dumb but hopefully easy to answer question. I was on Bill Hartman's site and he gave a really general recommendation of starting wide infrasternal angles in supine and narrows in prone for exercises, so like quadruped, things like that, due to the gravitational effect. Let's say I wanted to improve shoulder external rotation for a wide infrasternal angle. Would low reaching for posterior to inferior expansion in supine block expansion due to the table? If the answer is yes, then my question becomes, why would wide start in supine if generally you're trying to achieve inhalation or posterior expansion? Thanks in advance. This is quite a good question. I'm excited you asked this. So let's talk about positions first in terms of who to start what where. If we compare wide to narrow infrasternal angles, and let's just say this is a classic wide ISA or a narrow ISA, they have baseline levels of compensations. What I mean by that is you have someone who has just like the first layer of compensation. So if it's a wide infrasternal angle, they're going to have more concentric bias on the back side of their body. If it's a narrow infrasternal angle, they're going to have more concentric bias towards the front side of their body. And the reason why this has to do with the pelvis. My grandson coming in for the win. So with the pelvis, with a narrow infrasternal angle, they're going to be more counternutated, falling backwards, meaning front side's going to concentrically bias to upright, and vice versa for a wide. A wide is going to be more nutated, spine falling forwards. They're going to be more concentrically biased on the back side of the body. And that's the first layer of compensation. If you want to learn more, I will link a debrief in the show notes where I really deep dive into the layers of compensation. The show notes will be found on zachcouples.com/ISA. So let's talk about what Bill is discussing here, because he mentioned wides, supine position, narrows, prone position. What's the deal with that? Well, I'm glad you asked. If I put a wide in the supine position, gravity is going to be acting downward, and it's going to push the viscera and air downward. So you'll get more posterior expansion of the spine, which, if I'm concentrically biased on the backside of the body, you would want. So it's not a bad thing. For a narrow, and this is why like quadruped's useful for a narrow, scratch that. If I'm in prone or quadruped, now I have gravity still acting downward, but the guts and air is going to be more easily pushed forward, which is going to allow for better eccentric orientation of the front side of the body. And that's why those positions for those people who have primary compensations are quite useful. Now, one question that my homeboy Tyler asked was, well, Zach, doesn't lying on your back block airfill? No, I don't think it does. Because you got to think about it this way, right? If I do some type of reach where my thorax is going backwards, I'm creating a relationship where the thorax is posterior relative to the scaps, and that can allow for some posterior expansion. If I'm on my back and I'm reaching, I still create that relationship. And really, in my opinion, because Tyler mentioned low reach, I haven't been using low reaches as much for wides for a couple reasons. One, a lot of times, especially if there's a secondary compensation, when a wide performs a low reach, they have a really hard time not engaging the pecs. If you are unable to reach without tensing your pecs, that's going to limit your ability to create posterior expansion. So that's one piece. The other piece, think about why the wide infrasternal angle is limited with posterior expansion. If they have a posterior expansion restriction, that is secondary to their structural bias. So if based on their ribcage structure, they have a nutated sacrum and they concentrically bias the back side, I find it actually more effective to get posterior expansion by manipulating the dynamics of the structure. So for a wide, if their ventral cavity is larger side to side and it's closed front to back, to me, it's much more effective to do things that compress the sides that would inherently give you some A to P expansion and oftentimes can improve the posterior restrictions you see with wides. That's why I start most wide infrasternal angles in the side-lying position. Because if you go to the great article by Takashima et al., 2017, I'll link it in the show notes, don't worry, you boys got you. If you go to that article, lying in the side-lying position will compress the lateral dimensions of the rib cage and increase anteriorly and posteriorly the anterior and posterior dimensions. That's why I like side-lying for a lot of my wides, because I can take advantage of that. That's especially true if they have secondary compensation. Stay tuned because I'm going to talk a little bit about that. For the narrow, you kind of have similar issues, or why a lot of times I will start narrows in supine is because, same article, Takashima, if you lie them in the supine position, that's going to increase the lateral dimensions of the rib cage, which is really useful. So I think supine or prone can be useful, assuming that they can keep a good stack position for a narrow infrasternal angle. And I'll talk a little bit more about the stack later. Stay tuned. Let me just recap that real quick. Wides, supine can be useful if there's a primary compensation, namely they're concentric only on the back. I gravitate more towards side-lying because that takes advantage of compressing the thorax A and P. Narrows, prone, or quadruped can be really useful because of the gravitational effects. That will allow expansion more readily anteriorly, especially if that's the only compensation. But I think, in my opinion, supine is also useful because the supine position can increase the A to P dimensions, as long as you're being mindful of how they're stacking. Now, here's the issue. The issue is very rarely, and maybe this is just the population that I work with, but very rarely do you see a narrow or a wide infrasternal angle with only primary compensations. Usually they've thrown some other things in the mix, and that's leading to them having some more restrictions present, which we don't necessarily want. Now, let's take into consideration if they have a secondary restriction. Let's start with the wide. Why might supine not be useful for a wide ISA? If I have a situation where I have a secondary compensation for a wide, and what that would mean is they would have concentric bias on the front side of their body. So you're no doubt going to have the guts pushed more posteriorly as well as air, but also too, I'm going to have more concentric bias of stuff on the front because now gravity is pushing me further into that compensation. Think of it this way, right? So if I have a situation where my pump handle's down and I'm lying supine, the gravity is going to push me more down. So in that case, the supine position could be more challenging actually for a wide ISA. I've noticed this quite a bit with certain strategies if I've tried it in supine, because a lot of times you'll see someone try to tuck or they'll get an exhale, and these people, they'll really crunch down, and you'll see with a wide, you'll either see the belly start to flare out or you'll see a diastasis recti form, which what that is it's just a bowing out of the rectus abdominis. Kind of looks like they have an alien growing out of their stomach, which is undesirable, because when I exhale, I want the abdominal wall to compress or get smaller. If that doesn't happen, then you're not going to get good movement options, which again is another reason why oftentimes I prefer side lying for those people. Or what I've also found useful is if I do mess with supine and it's a wide who has a secondary compensation, I actually like the Lewitt position where the hips are at 90 degrees at the hips and knees. That seems to work pretty well also. Other positions that I like for wide starting them, if I have someone who's got secondary compensations, would be standing supported. That's also another great position to start a wide in. For the narrow, we actually have similar issues in quadruped if they have secondary compensations. A narrow secondary compensation is to go concentric on the back. If they're concentric on the back and I put them in prone or quadruped, you run into the same issue. If I'm concentrically biased backwards, that means I tense everything up in the back, the thorax migrates more anteriorly. Now I got gravity pushing me down. Oh crap, now I'm going to get pushed more and more into that position. You got problems. So for those folks, you might actually use supine, and supine is a lot of times much more effective because you can take advantage of gravity to push the air and viscera posteriorly to deal with that secondary compensation. That's why I think supine is useful for a narrow. In fact, I had a guy this week. He was a narrow infrasternal angle, and your boy was secondary compressed or compensated AF. He had limitations in all directions, shoulder mobility wise. Had I started him in quadruped, his back would have just stayed flat. We would have increased the posterior compressive strategy going on there. So I elected to start him in hook lying, and we did a low reach. With the low reach, he was able to get a good reach. He wasn't over kicking in rectus abdominis, and he was able to feel posterior expansion in that region because we created that scapula forward, thorax back relationship. And after he did a few rounds of a hook lying single arm reach, which I'll link in the show notes because I like you folks, after he did that, we had almost full ER, and I think he started at like 40-ish both sides, and we got him to about 80 with just that move. Less pain too, which was really cool. So the point being with this is the rules aren't necessarily cut and dry in terms of where you should start someone. It all depends on what restrictions they have present. For me, if you have only primary compensations, a wide with a loss of flexion abduction ER, a narrow with a loss of extension adduction IR, you can start them in the case of a wide supine, the case of a narrow prone. But if that's not the case, you got other restrictions at play, which is most people. It's much more useful for wides to either start in side lying or standing. I don't use quadruped necessarily because that will still increase the concentric bias posteriorly. For narrows, I like supine, and I also like standing for them as well. Anything also for a narrow that's more inverted, like the drunken turtle, those are great moves as well for those who have secondary compensations. And those are generally the positions that I like to start my clients in. Great question, Tyler. The next question comes from a couple people. Becca from YouTube. She's like my sister from another mister on YouTube because we chat a lot. And then Adam Mustafa 23. They both want to know about the stack. What is it? How do you make it happen? What's going on? This is probably the most important question I will answer ever. So, if like you are sick of me and you're like, I'm going to stop listening to you, this would be the debrief to do it. What is the stack? Why is it important? If we're talking about restoring movement options, to me, the stack is the most important thing to coach. Also, too, I would argue if you're trying to move some big weight, you want to move well in the gym and on the field, you probably need to have this mastered. What the stack entails is putting the pelvic diaphragm and the thoracic diaphragm relatively on top of one another. What this is going to do is it's going to allow for the respiratory mechanism. When you breathe in, both diaphragms will descend and expand the ventral cavity in all directions. When you breathe out, both diaphragms will ascend and compress the ventral cavity in all directions. That's going to allow for adequate development of both intrathoracic and intra-abdominal pressure. It will give you the potential to have all of your movement options available within the ventral cavity and many other good things. That's why it's super important, because most people, if they have some type of compensation going on, there is likely a loss of that respiratory mechanism for a wide variety of reasons. The stack is the first step in improving those dynamics. What that will entail, more often than not, is a posterior tilt of the pelvis, because with most compensatory scenarios, there's an anterior tilt or orientation of the pelvis. That's going to change the position of the pelvic floor or the pelvic diaphragm and is not going to allow for an effective stack. In the terms of the thoracic diaphragm, with most compensatory situations, the diaphragm is going to be more descended, albeit to varying degrees depending on if you're a wide or a narrow infrasternal angle. A wide infrasternal angle is going to have less of a descended diaphragm compared to a narrow. But both will be descended if there is a loss of movement present. So we need to do things to ascend the diaphragm to the nth degree. That's why I coach the snot out of a full exhalation. What that does is it drops the lower rib cage down, which a lot of times you'll see the ribs flared out on folks who have a loss of movement. It'll drop the lower rib cage down, allow the diaphragm to fully ascend, and get your diaphragms in a stacked position so you have all of your movement available to you. That's why the stack is important, and that's why, of course, if you can't stack, I say don't talk to Zach. But from my standpoint, that's going to make me really lonely, because a lot of people have a hard time coaching and performing the stack. This is like my job, is to teach people to stack. I want to talk to you folks, so I'm going to teach you how to do it. First thing, I start with a posterior pelvic tilt of some sort. The way I coach it depends on which infrasternal angle presentation you have and if you have primary or secondary compensations. Let's say you're a wide infrasternal angle. More often than not, I teach the stack in the side-lying position for reasons I had mentioned previously. The way I coach it is a few different things. And I have a side-lying tilt progression and a hook-lying tilt progression. I'll link those in the show notes because that will give you a nice overview of how to do it. But what I coach is some type of posterior tilt in side-lying, cues that I like. And this is true regardless of infrasternal angle presentation. I'll either say pull your belt buckle to your belly button. I will say imagine someone's pulling you by the back pockets towards your knees or your heels. This is one I like a lot, squish your butt flap to your thigh. Or if those three don't work, I will actually have the client, I'll say arch your back, pretend you're Jennifer Lopez or Kim Kardashian, whoever you prefer. Personally, I prefer Jennifer Lopez because I had a crush on her as a kid. But Jennifer Lopez, now I want you to un-J-Lo yourself or pretend you're Michael Jackson and go the opposite direction. that can be a very useful cue for anyone. If they can't get into the position you want, have them go the exact opposite direction, and then that will give them context of where to go in the opposite direction, and that can be a really useful cue. Generally, those 4 cues will work. If they don't, then either the position is too challenging and you need to go with something else. So in the case of a wide who's in side lying, maybe you need to do a manual technique where you really drive the knees up towards the chest. That could be a really useful way of getting it. Or you do some type of passive tilt, where that might be actually putting them in supine, either hook lying or in the Lewitt position, and put something underneath their sacrum so they create a passive tilt. MCI Cicerone 1, in regards to the side lying position, do I put feet on the wall for reference with side lying? Yes, I do. Thank you for saying that. So with the side lying tilt, and I usually do this at about 60 degrees of hip flexion, and that's because that will aid in sacral counternutation. I will have the feet up against the wall, and the first part for a wide is to get the tuck, however you coach it. Now, the issue with side lying is you don't necessarily get good hamstring and glute recruitment just tucking in that position. So I will have them, after they get the tuck really well, push their feet into the wall. That can allow them to get the glute and hamstring recruitment that we desire. Once you have that, then what you're going to do is have them hold that position and breathe in that position. With the exhale, you want them to get as much air out as humanly possible. The goal is to get the diaphragm to ascend. If they can't get the diaphragm to ascend all the way because the exhale is short, you're not going to get the stacked position. You're not going to get the movement options that you need to restore. So you want to get a full exhale out. For a wide infrasternal angle, because you're trying to close the rib cage, you want to make the angle smaller. I go with a pursed lipped or a kissy face. I always go like your duck face on IG, or you're flickering a candle. Have them exhale that way, because what that's going to do is it's going to create a little bit of resistance, which will encourage more superficial musculature activity, especially external obliques. You need that for a wide because you're trying to close that angle, so you need more tension in the abdominal area. But you still want the exhale to be slow. So that's your other piece. Once you get that full exhale, you want to draw attention to them and say, hey, are you feeling a little bit of ab tension when you do that? And a lot of them will say, well, yeah, Zach, I am feeling some ab tension. That's wonderful. If they're not, they just might not have that sensory awareness. So what you can do is have them put their hands on their abs and use that as a way to develop that sensation. Maybe they're just not getting a full enough exhale to get the ab tension. In that case, what you can do is assist them manually by pressing down on the lower ribs gently during the exhale. Don't push too hard because it'll be uncomfortable. Once they get the sense of feeling that ab tension and they get a full exhalation, then what you want to do is teach them to maintain that tension during a pause, 3 to 5 seconds. That's going to get them used to sustaining that ab tension, which is needed during the subsequent inhale. Get the tension. Do you feel it? Yes, I do. Can you maintain it during a pause? Yes. Or maybe they can't pause long because they feel like they're going to suffocate. That's okay. The reason why that happens is because they have low carbon dioxide tolerance. Just work on them improving their pause capabilities and holding that pause. Once they have that, then what you're going to do is encourage them to keep the ab tension during the inhalation, during the subsequent inhalation. Because what that's going to do is it's going to anchor the lower rib cage down so you can get circumferential expansion in the rib cage. Because if they can't keep the ab tension, what's going to happen is they're going to either belly breathe, more often than not with the wide, meaning that they're not going to get any expansion in the upper thorax, or they're going to lift the thorax up as a unit by utilizing accessory musculature. If that happens, you're not going to get expansion in the upper rib cage. So either of those are problematic, and we don't want that. That's for a wide infrasternal angle. Start with side lying to get the tuck and the tilt, coach the breathing the way we talked about, and you should be in business. Now, if you have someone who's wide and they have a secondary compensation, side lying can still be useful. But I've also found for those folks, teaching it in seated can also be quite useful just because it's easier to get a tuck. If you have a wide ISA who's just got the primary compensations, hook lying is a good position to start them in. If like side lying just isn't cutting it, maybe it hurts to lie on their sides and they are a wide with secondary compensations, then I would go with a Lewitt position or 90-90. So that's the wide. The narrow, the coaching and sequencing is very similar. What changes is a little bit of the exhalation and the positions that you start them in. If I have a narrow infrasternal angle, generally I will start them coaching the stack in supine as opposed to quadruped. And the reason why is because they can get better visual appraisal of what I'm doing or what I'm teaching them on how to do it. I'll start in the Lewitt position if it's a primary compensation, loss of extension adduction IR. If it's a secondary, they lost flexion abduction ER, I'll start them in hook lying. Same cues for getting the tuck as the wide. The one thing that would change is if you're using the Lewitt position and they still really are struggle bus when it comes to tucking, you can have them dig their heels down onto a ledge, or a cue that I like is pretend you got doggy do on your shoes and you're scraping it off the wall. That can be really useful to help them get the tuck because they might not be able to generate enough tension with proximal hamstring distal glute. So you can use distal hamstring to get the tuck. It's not ideal always. So get that. Coach the exhalation the exact same way. The only difference is you're going to have an open mouth sigh. Like you're fogging a glass window or you took a drink of water. One of those. Both of those are useful. What you'll find with an issue is during the exhale with narrows is they just won't open their mouth. So I'll say, take a big bite out of an elephant. Don't do that at home. Or I'll say, no, open your mouth, like really big open. Imagine I said something incredibly offensive and you're shocked. Sometimes those will work, but a lot of times you just have to keep reinforcing that over and over again. Another thing could be if you're too close, they might fear that they have bad breath and don't want their stanky breath all up in your grill. If that's the case, move away and just say, hey, I'm going to move away. I want you to just get that open mouth exhale. They might be more comfortable with that. And then the process is the same. You're creating the ab tension with the full exhale, hold that during the pause, and then maintain it during the subsequent inhale. Now, a couple other specifics to consider for wides and narrows in terms of what you're going to do with the legs. With a narrow, generally, if they have a primary compensation, you're going to adduct the legs together. So if they got a ball between the knees, I would squeeze that. And the reason why that is because if you're adducting the legs, that's going to help pull the infrapubic angle apart, which a narrow ISA needs. Because if I have a narrow infrasternal angle, structurally, my infrapubic angle, this angle below the pubic symphysis, the IPA, the favorite kind that I like to drink, needs to be pulled apart. You don't want that with a wide ISA because their infrapubic angle is going to be wider. So for them, I will either hold a ball or something between the knees or put a band around the knees and create slight amounts of external rotation. Those can be quite useful. If you have someone who's got a secondary compensation, scratch that. For a narrow ISA, I will just have them hold the ball in place, or for a wide ISA, same thing. I won't drive any excessive AB or adduction. Just keep everything in a straight line. That seems to be quite useful. And the reason why that is because you're going to be changing the position that you're going to be placing the extremities in. So like for a narrow, If they have a secondary compensation and I'm utilizing hook lying to teach the stack, well, I don't want to adduct in that position. And the reason why that is because the hook lying position is going to drive more counter nutation. There's a debrief where I dive deep into that, so check that out. I'll link it. So I don't necessarily want the squeeze there because then I have contradictory mechanics at play. Same thing with a wide. If I have a wide who's got a secondary compensation, I could actually put the hips at 90 degrees, but I don't necessarily want to squeeze because they still have the structurally wide infrapubic angle. So don't worry about getting fancy in that regard. And those would be the big keys when we're talking about stacking. In terms of compensations you may see, like how do I know? I get this a lot too. Zach, how do I know that their tuck is on point? A few things you can check. One, look at the abs. If they tuck, they should have minimal ab tension. If they're tensing their abs like gangbusters, they're not getting a good tuck. If you see the abdominal contents push outward during the tuck, they're not tucking. Because what's happening in that case is they're concentrically biasing their back, and that's pushing the guts forward. We don't want those things. You want minimal abdominal movement during the tuck. So you might need to either finagle your cueing a bit, try something different, try a different position. Any of that can be useful for getting that. With the exhale, you can see the same compensations at the abdominal region. Generally, that's because they're exhaling too quickly, so I will coach them to go softer, get as much air out as possible, get it all out. During the inhale, if they see a loss of ab tension, well, you'll see that either one of two ways. Either you'll have just this huge belly breath and nothing going on to the thorax, or you'll see a lot of neck tension kick in during the inhale. That means that they're not keeping adequate ab tension during the inhale, and you might reinforce that. And really, folks, if you can do those things, you're going to have a pretty good stack, and you will have permission to talk to Zach. To summarize, tuck first, use whatever you need to be successful. For wides, I like starting in side lying. For narrows, I like starting in supine. You can manipulate leg position based on if they have primary or secondary compensations. For a wide, that would mean primary compensations would start at 60 degrees of hip flexion. If they had secondary, I would start them closer to 90. For narrows, I would start them at 90 degrees of hip flexion, the Lewitt position. If they have secondary compensations, I'd start them in hook line. Coach the exhale. Make sure the ab wall drops down during the exhalation. You want it to be slow, controlled, get as much air out as humanly possible. For wides, kissy face, wind impression. Narrows, open mouth exhale. From there, you want to create ab tension with the exhale. You're not going to force it, but the exhale should create tension in the abs. You want to maintain that during a pause, during an inhale, and you can bet your bottom dollar that you won't fail. The next question comes from Mikhail. Here's what Mikhail asks. Hi, Zach. Many thanks for what you're doing with the FAM education. We all very appreciate it. I appreciate you, Mikhail. I have a question. In someone who's narrow, the diaphragm is stuck so low that it pulls the ribs together. So should that person have his ISA even narrower upon inhalation because the diaphragm moves down even further? Typically, I can see the narrows can expand their bucket handle during inhalation. Awesome question. So let's talk about what Mikhail's talking about. With a narrow infrasternal angle, because of the shape of their ventral cavity, their diaphragm actually descends significantly farther than a wide infrasternal angle. If the diaphragm descends towards flat, the diaphragm changes its line of pull on the lower rib cage, and it actually causes the lower rib cage to bow inward. This is going to give leverage to the external obliques, which is what creates the narrowing of the infrasternal angle. So what Mikhail's asking is, well, Zach, shouldn't we actually see the narrowness close even further during inhalation. If you're dealing with compensatory mechanics and you're not coaching the stack, as we talked about before, yeah, you can actually see that. This is where paradoxical breathing can come into play, where you see a mismatch of the breathing sequence. Now, one thing that you're seeing that you mentioned is I actually see narrows who can bucket handle. I want to tell you, Mikhail, that chances are that person is a dirty liar and cannot be trusted. And I have this one girl, she's going to know if she's tuning into this. I have this one girl who stands out. She was at my San Antonio Human Matrix. And people were measuring her. And they're like, Zach, you got to check this out. And her bucket handle, I measured her ISA, and it was narrow. And her bucket handle would go like whew, crazy out, and then it would go crazy in, and it would do so very quickly. And I said, that's interesting. And so what I did was I measured a lot of her other measures, and she was restricted. And I was like, I wonder what you're doing. I put her in quadruped to see if she could get the stack, and she failed miserably. What she ended up doing, and I rechecked her infrasternal angle, I put my hand on her upper back, and when she breathed in, what she did was she, compressed her upper back into the ground as hard as she possibly could. And what that did was that arched her back enough that it gave like a pseudo bucket handle positioning. So really what she was doing was she arched her back and utilized superficial musculature to pull the ribcage in a funky manner. And she couldn't maintain the stacked position during a challenging exercise like quadruped. So she's a liar. I'm just kidding, homegirl. You know I care about you. A lot of times with these people, you can't just hang your hat on the infrasternal angle presentation. You have to look at other measures to see if they have dynamics or not. If it looks like they have dynamics, but they don't have, they're very limited in other measures, I wouldn't hang my hat on that. What you have to do with a narrow ISA is you have to create an ascended diaphragm as much as humanly possible. And that's why the full, slow, open mouth exhale is so useful. It's useful because if you did a hard exhale, what would happen is because the external obliques have leverage is they would just compress the rib cage even further and you wouldn't get the diaphragm to ascend adequately, which is going to limit your expansion capabilities throughout the ventral cavity. If I do a slow, controlled exhale where I don't get much recruitment of the external obliques, then I have the potential to allow the diaphragm to fully ascend, giving me the possibility of restoring the normal respiratory mechanism and allowing full movement options to be accessed. And that's the key with narrow ISAs. You got to be careful, especially if they have some degree of eccentric bias. They can do a lot of crazy cheats. Don't trust it if you see good bucket handle dynamics, because you still probably have to work on the stack. And if you're unsure, put them in a position like quadruped or something that's challenging. See if they can stack. If they can't, then you can bet your bottom dollar that they are likely cheating the tests in some way, shape, or form, and maybe your test is actually that position. Great question, Mikhail. The last question comes from Ben. Here's what Ben asks. What moves do you like for the obese, chronic pain, or non-English speaking clients? I like a lot of your exercises, but some of these folks seem to struggle with performing or understanding them. Anything regarding initial work towards establishing a dynamic ISA would be appreciated. Thank you. This is an awesome question, and I feel you, Ben. These are all tough populations to work with, and I've worked with all of them. So let's unpack each one. First, the obese population. What you have to understand with this is you want to keep your expectations tempered. Because if I'm obese, the obesity is essentially a structural impediment within the abdominal wall. And what I mean by that is the abdominal contents are incompressible, and you only have so much movement available. So it's not like I can make them smaller. And when you're breathing in and out and you're moving in these positions, ideally you should be able to push the viscera every which way in order to allow for movement to occur. But if I'm throwing a bunch of abdominal fat there, especially if it's visceral fat, well, now I have a situation where I have a significantly harder time moving the viscera throughout the abdominal region, especially if the visceral fat has created such an eccentric bias into the abdominal wall. Well, what happens is now I can't generate enough tension on the ab wall to push the viscera where I need to. And I might not have enough space to push the viscera to where I need to because it's taken up with fat. So you have to be mindful of that. And a lot of times what you'll see is some positions are no-goes. Like when we talk about putting a wide in supine, good luck if they're obese. Because what's going to happen is you have all of this downward pressure and you can't push this visceral fat downward, like it's going to be a no-go. For that population, I think side lying is very useful. I also think for the obese population, sitting activities are extremely useful to get a tuck. Because the tuck with sitting is almost passive. And you can allow them to kind of rock back and forth and see if they can feel their butt bones. But realize that the degree of obesity is going to limit how far you'll get. So you're not going to see like this dramatic rounding of the lower back with your posterior pelvic tilt in that population. What I would say with them is do the best you can. If they can feel glutes, hamstrings, or you can palpate and feel the glutes and hamstrings working, chances are you're probably going to get some favorable changes in movement options. And then exhalation-wise, measure the infrasternal angle as best you can. Just because they're obese doesn't mean they're a wide ISA, because remember, that's a structural thing. What's going to change is where they carry fat. A lot of times with wide infrasternal angles, based on their pelvic diaphragms, they're going to have more of a like hard belly. Narrow infrasternal angles are going to have more of a pooch belly. So you can still measure the infrasternal angle, but I would still stick with positions where they can get some degree of exhalation without getting too much compression in the upper thorax, because that's generally what happens with someone who is obese. Utilize side lying, utilize supine, utilize standing positions, and those should be useful at improving their dynamics. Now that's just for movement options. What could be one of the best things for this population in terms of improving their movement options is doing anything in your power to make sure that they can lose weight. Because if you can decrease abdominal fat, that will actually allow more visceral movement because you have less of a structural impediment. So this is where machines can be useful, because that's going to stimulate metabolic processes, so they burn more fat. Having them walk or bike, and then making sure their sleep's on point and their diet. So really helping this population is going to be a very comprehensive approach. Obviously doing things like motivational interviewing and things like that can be really useful from a dietary perspective. So you want to consider that with obese clients. Next, let's talk about chronic or persistent pain. Any position is fair game, but what you want to do is find a position, any of the ones that I talked about previously, that doesn't increase their pain. It's okay if they have pain at baseline. You just don't want to turn the volume knob up with an activity. And when we're talking about the stack, I would slow cook coaching it as much as possible. Perhaps session 1 is just having them focus on the tuck, see how they respond, and then you can focus on the tuck with the exhale, see how they respond, and then build it up that way. And really the key with persistent pain is you want to add a little bit of activity, see how they respond. If it goes well, then you can add a little bit more. And if you go slow, a lot of times you can really increase their activity levels without having some type of flare-up. But there's always going to be that, give them something new, see how they respond, and if it's really negative, then you have to scale back. Now, with persistent pain, What I mean by really negative is, if their pain increases and it stays that way for several days, like a week. Generally, if I have a patient or a client who has aches or pains like 24 to 72 hours afterwards, and then things are good, I'm generally okay with that. And I'll likely keep them with the same volume or type of activity. And a lot of times after that, they'll respond favorably. But if it's like I did something and it's weeks on end of pain because of it, that was probably too much and you'll need to scale back or change the context, change the position. So that's what I would recommend for someone with persistent pain. Lastly, we have non-English speaking clients. This is really tough because you can't rely so heavily on your verbal cues. So with non-English speaking clients, you want to keep things as simple as possible. So really scaling back the amount of coaching that you're doing, using your hands-on cues, really useful. Don't give them too complex activities. What you're going to rely on a lot from a coaching perspective is you watch me and then you reproduce that movement. So you might say, here's your move, tuck, whatever it is. You try, and then you do 10 or you do your hand counts or whatever. So have them tuck, make sure that it looks good. And then if they're screwing up, you need to show them their compensation. And that's where like even learning just yes and no in their respective language can be really useful. So you might go, watch me, see, if it was Spanish, and then what you did, do the compensation, no, do what you did again, see. And, like I've worked with a lot of people who speak a wide variety of languages. So if you can learn yes, no, or some basics in those languages, it can definitely help you quite a bit. But for people who don't speak your language, you want to utilize your body as much as possible. And that's where making sure that you can demonstrate these movements and demonstrate the compensations can really up your coaching game. And that's true even if you have someone who speaks your language. If you can show them right and wrong, they're going to be more receptive and better reproduce what you want them to do. And that's where I would go with coaching people who do not speak English. Great questions. I think that's a good stopping point for us today. It's hot in here. I want to thank you all so much for tuning in. You've been a beautiful, sexy, outstanding audience. If you want to learn more, go to zachcouples.com. There, I would subscribe to my newsletter. I offer a free workbook called Common Compensations where you can look at some of these movement restrictions that are available and learn how to coach your people through that. You'll also get access to Human Matrix Foundations, my free seminar. I also offer a seminar called Human Matrix, which is currently offered in person. It's really going to depend on where COVID allows and doesn't allow. Unfortunately, I have to postpone a couple of my next ones, but I do have some coming up. Check them out in the show notes to learn more. Services-wise, I offer movement consultation, mentoring, online training. The movement consultation can work on teaching you how to stack effectively because maybe you're not moving as well as you'd like to, or your squat doesn't feel great and you want it to feel great. A movement consultation can help you with that. I can teach you how to do that or give you feedback on how you're coaching your stacking with the mentorship program. And unfortunately with online training, I normally would, blast that, but I am at max capacity. But if you want to get on the wait list, just go to zachcouples.com, sign up, and I will put you on the wait list for new training clients. Once you've scoured zachcouples.com, you've checked the services, you read a bazillion blogs, you might want to check me out on Apple Podcasts and Stitchers. Because guess what, folks? There's 126 other debriefs. You might want to listen or look at me for all of them. So check me out on Apple Podcasts and Stitcher. Please leave a review so the fam can keep growing. Social media-wise, I'm on Facebook and Twitter. Search Z Couples. Of course, I'm on that Instagram, baby. Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And last but not least, peep me on YouTube if you want a gang of exercises with when to use what. You definitely want to check me out there. And that's, of course, where the high-quality version of the movement debrief will be, as well as other stuff. Thank you so much for tuning in. You've been a beautiful, sexy, outstanding audience. I want you to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces. Pow.